Hey everybody, welcome to the Shreveport Bossier Local Lens Podcast. I'm your host, Jeremy Sutton. I'm here with Dr. Ghattas for the second time. We're going to be talking about his oncology practice and a little bit about Gladiator Men's Health as well. But let's get into that. Dr. Ghattas, thanks for being on the podcast.
Thank you for having me, man, again.
Yeah, you're the first person I've had twice, so congratulations. I don't. There's a prize. I'll figure it out later. Well, just tell us, what we're going to be talking about today and introduce yourself a little bit more.
Well, I mean, I think today we're going to focus on my oncology practice. I am double board certified in oncology and internal medicine. I was in internal medicine since 2005 to 2021. So I've been doing internal medicine for a long time. I did come to the state in 2010 and did my internal medicine residency here at LSU, actually. Then I worked as a hospitalist for 8 years. I was at Christus Hospital doing hospitalist. Then while I was doing hospitalist, I was chief hospitalist at Christus Highland for about 1.5 years. Then I was a regional medical director. I was managing what we called at that time PPCI from Medicare or value-based care. We had was covering the whole Gulf region at this point. I was covering Texas, Louisiana, Florida, Oklahoma. Was a sound physician. Did that about a year, and then around that time. I was blessed with Rafi, my first boy, and I was traveling a lot.
Yeah.
So I think I had like 80 flights in the first 6 months of my regional medical director. It was a busy job. Then I didn't see that I can do that for a long time with two new boys in my life. So I decided to go back as a hospitalist again, and that's when COVID hit. I mean, I literally went back as a hospitalist on March 2020, and we got the first COVID case that week.
Wow, what a great time to go back to the hospital.
And the next 3 months, that was the first wave of COVID. The next 3 months was terrible. I mean, I have lost a lot of people in the first wave of COVID.
Right.
Then I decided, you know what, this is enough of internal medicine. I always wanted to do hematology oncology. As a matter of fact, in 2012, I applied for hematology oncology here at LSU, but I had some financial commitment to my brother and my family, and I needed to take care of him, so I had to get out and go to private practice. So I applied in 2020 and I got accepted, match in December 2020, then did my fellowship, and then I have been working with LSU Arsenal for 2 years now. My main focus the last couple of years was breast cancer, prostate cancer, renal cancers, and malignant hematology cancers like lymphomas and myelomas. That's what I have been focusing on the last couple of years. But that's how I ended up here, and now I'm 2 years in.
Yeah, that's awesome. How hard was it to go? I know it wasn't hard, but what was the mindset shift between internal medicine and oncology hematology? Was it a difference, or can you just go right into it?
You know, we were talking a minute ago about how everything you do in life open doors for you, or everything you do in life, it builds you for something else unconsciously. The difference between what I was doing for years and years, first of all, I've seen patients in all different kind of settings. So
Sure.
Before I went into oncology, so I was rounding in the hospital, I was rounding at LTACs, I was rounding in nursing homes, I was medical director for home health companies. I was medical director for rehab companies. I was medical director for hospice company. I was so I have seen every patient in every setting in the healthcare system before I went to oncology. And the big difference between what I was doing and oncology is the patient-physician relationship. Because my relationship with those patients in a hospital medicine was temporary and was transactional in the sense of I need to take care of you in this acute setting. When you compare that to oncology, it's not transactional anymore.
Right.
You become their doctor.
Yes.
And 99% of them, you're the only doctor you see from now on. So sometimes I have to manage blood pressure with oncology, sometimes I have to manage diabetes with oncology, sometimes I have to manage acute renal failure or all of that. So that is a big difference. The other difference, the other major difference is internal medicine and hospital medicine is stagnant in a sense of the knowledge.
Yeah.
Most of it just has been there for years and years, and there's no new advances. As there is, but it's not every week. In oncology, if you're not updated every week, I mean, literally, if you're 3 weeks without reading or keeping yourself updated, you're outdated.
Wow.
So I go from maybe reading an article a month in hospital medicine and internal medicine. Now I have to spend 6-7 hours every week to keep myself up to date. The other thing is you have guidelines, you have ways to treat cancer, you have all of that, but every patient is very unique. So sometimes, even if you know the answer to how to manage that situation with oncology, you have to go back and spend a lot of time researching, okay, maybe I need to add this so I can improve the outcome a little better. Well, this patient didn't improve in this, but maybe I need to spend more in this medication. Let me figure out if he's going to be a candidate for this regimen or not. And that takes a lot of time.
Yeah. Is there an art to this as well as a science?
Oncology is the art of medicine, basically, because you have your guidelines, you have your knowledge, but the way I look at managing patients with cancer, I look at it as a triangle, okay? At the top of that triangle is the patient. Every patient is different in their phase of life and their goals of life and what can tolerate and what cannot tolerate. So this patient is very unique to this. So a 40-year-old with a triple negative breast cancer that has a kid that is 5 years old, their goals in life is going to be completely different than a 75 years or 85 years old with triple negative that have lived their life to the fullest.
Sure.
So that's at the top of the triangle. The other angle of that is me as an oncologist, with my knowledge, my experience, and my experience in life. Because I come to this with 14-15 years of experience on internal medicine before that. That's make a huge difference in the sense of you're comfortable with having discussion, you're comfortable
Yes.
with managing other noise of other hypertension and all of that. Cancer is the third angle of that triangle. And cancer, you have to think of it as it has its own mind. Because the way that cancer is evolving, it evolves like anything else. So you start with a certain reason that you have this cell to go rogue. That cell went rogue because you have a mutation or it has an environmental stress like smoking causing a mutation or exposure or just a random act of evilness, that cancer, but then you start treating the cancer and then it evolves with time on what is the driver, what is driving this cell now to become unresponsive to the treatment. So if you keep looking at managing the patient within that triangle of me, patient, and the cancer, then you have to have art to manage all of that together. Because you have to make a decision based on what does the patient want, how is the cancer behaving, what is my comfort level. Because sometimes we use drugs that we never used before. Like there's always a first time for drugs that was approved last week.
Right.
So if you're not comfortable to managing these side effects, but the cancer is evolving, then you're not serving that patient right. But if the patient is not 85 years old and doesn't want to spend their 2 years left in life and a lot of side effects, I understand that.
Sure.
Then I'm not gonna go aggressive even if the cancer is going aggressive.
Yeah.
That's the art of oncology, and most of my time is spent on how to handle all these variables at the same time.
Yeah. Yeah, I can see where that would get difficult and nerve-wracking and things. So I want to go back to something you said. So acute care being more transactional, oncology being less. So my dad had cancer, non-Hodgkin's lymphoma. He got through it, but he was in Ruston. I wanted him to come here to Shreveport to get treatment, and he ended up seeing Dr. Thomas Moore, who's passed away a few years ago. But he heard horror stories about Dr. Moore from a waiting room in a doctor's office. I was like, look, nobody tells the good stuff in the doctor's office. They want to be the worst patient, right? So he came. Dr. Moore was phenomenal. Took great care of him. We called the nurse. I think her name was Pam. They just built this relationship.
Yeah.
Exactly what you just said. And I would say that's the best care my dad has ever gotten, healthcare wise, his entire life. So I appreciate that it goes from kind of a transactional, which we're not saying that in a negative way, because I've worked in acute care too. I know how it is. Like, people are here for a few days. We're trying to get them better.
Right.
They move on to whatever else they need.
Right.
But I do appreciate that it changes to a more person-based. We have to take care of it.
I'll have to be patient-centered. Otherwise, we're not going to be doing those patients a good service, because you have to put in mind this is the worst diagnosis, the most fearful diagnosis
Right.
that a patient can get.
Absolutely.
And you and I are in the midst of medicine, meaning that you can Google, you know what to look at it, and up to date, you know how to look at it. But most of those patients, they don't. They don't know what that is. They don't know if they're gonna kill them or not. They don't know what is overall survival. They don't know what is progression-free survival. They don't know any of that, even if they read it. They don't. It doesn't come across as comforting even if they read it online or something like that. So you have to be there for them. I'll give you an example. I just saw this patient yesterday. I was in Germany with the boys one, I think it's in July, and this patient had without saying a lot of details, had this abnormality in the CT scans, and I was above the Atlantic. I have my internet on the plane, trying to look up some stuff, some patient, and she texted me. She was messaged me either, I think it was in the EMR, and she was worried about this CT scan abnormalities, and I was able to talk with her while I was above the Atlantic still, and was able to schedule her. I was flying back Friday, scheduled her Monday, was able to see her Monday, get a new PET scan and get everything done, and yesterday she was telling me that she will never forget that, because she knew there's somebody out there have her back.
Yes.
And that's the difference.
Huge. Yeah.
That's the difference, because she's like, I will never forget that he did that for me. Everything turned out good, but that scare,
Right.
The scare that she had, now she has a metastatic disease, scared her to death. And just being responsive and putting the patient to be center of your care makes a huge difference.
Absolutely. I mean, so yesterday I took my mom to see Dr. Feibel over at Highland. He's going to do 2 hip replacements on her.
Yeah.
And I've been telling her for years she needed it, but you can't treat your family. It's hard. I love my mom. But we went and he came in and sat down with her. He didn't know I was there until he walked in, but he just took time with her. And like, she was in tears when he left because he's like, this is going to change your life. And I fully believe it. I've been trying to tell her that. But she left, and so what do you think? She's like, oh, he made me feel comfortable. He explained everything. I think I'm going to get excellent care.
Yeah.
Because he went above and beyond. He didn't just come in and go, oh, yep, here's what it is. You need hip replacement. See you in 6 weeks.
Yeah.
And which is exactly what you're talking about. Hey, you call him. I've got some, I try not to bother doctors even when I have their cell phone, but I called Dr. Byram a few weeks ago because my daughter had a concussion, and I was like, hey, do I need to take her to the ER? So he spent some time with me talking about, hey, do this. Well, he didn't have to. It was 5 o'clock on a Wednesday. He didn't have to answer the phone.
No.
And so when you're giving great care like that, one, I feel like as a patient I'm being taken care of. 2, I feel like the doctor actually does care, and I'm not just a number on a file. And it makes a huge difference.
Yeah.
And you're right. Cancer is scary. Like my dad found out he had cancer was 13 years ago. My wife was out of town. He called me and told me he had pancreatic cancer. I hung up the phone and cried on the floor for 45 minutes.
That's scary.
It's scary. The next day he calls back and says it's around my pancreas, and I screamed. I was like, "What is wrong with you?" But he had no idea, right? My dad was a manual laborer.
Yeah.
He didn't know there's a 2% survival rate on pancreatic cancer.
Right.
He just knew he had cancer. So what you're doing is huge, and there's not a lot of people taking care of patients like what you're talking about. I don't think. I haven't met a lot. So it's huge.
Well, in cancer care, you have to have a lot of empathy.
Yes.
You have to. You can't take care of those patients that are struggling with their mortality and don't have any empathy. Now it comes at a toll. It is expensive on ourselves as oncologists because you can't go and say, I'm going to be caring that much about those patients and don't give something of yourself
Sure.
towards that care.
It's a cost.
It's a cost.
It's a personal cost.
It's a very personal cost. And I mean, even my kids, 6 and 7 years old, they can feel it. They can feel it. I mean, some days are really bad days. No, some days are good days.
I understand. So I mean, I've had 3 businesses. My kids are 10 and 12, or 10 and 13 now, and they know. Like I used to, Mom's going to put you to bed. I'm going to interview somebody on a podcast. And like we were talking about earlier, we're just trying to get your name out there as much as possible so people know who you are, know that you care. But they don't see the nights when your kids are looking at you and going, "Hey, I want to spend time with you." And there's a sacrifice. So and you have to walk that line. But talk about what you're going to be doing next. What's coming on new? What are you excited about with your business and your practice?
Well, I have been with Oshner for a couple of years now, and I'm grateful for the opportunities he gave to me. I have learned a lot over the last 5 years. I have been with Oshner, but it's time to move forward with my original plan to go to private practice. So June 1st, I will be joining Highland Clinic with Dr. Katisha to be in private practice. I will have 2 locations, one in Monroe and one in Shreveport. And let me talk about Monroe a little bit.
Okay.
So I have been going to Monroe for 2 years now. The first year I was going 2 times a week. And then the last year I was going mainly Monday. I have a really, really busy practice there. The Monroe area cover about, I think they call it Area 7 for Louisiana Department of Health, or 8. It's probably 8. That area has 8 parishes. And if you look at the heat map of the cancer, it's very red. we're trying to figure out why it is very red, because um, there is some explanation why you have much more incidence of cancer in this area. Uh, Poverty, obesity, environmental factors, but still doesn't explain all of that.
Sure.
So if you take 100,000 of patients here in Shreveport, you will have about the incidence of 400 new cases of cancer a year. If you go there, it's 550.
Wow.
Um,
Big difference.
Big difference, and economically that area is not as thriving as Shreveport, and so you have a lot of Medicaid cover, which limits some of the treatments that you can get, but also it limits a lot of the prevention care that you can get in that area. So early diagnosis,
It's hard.
hard. So you get a lot of the cases there that late diagnosis, metastatic stage 4. There is from also, I don't know, this is maybe a coincidence, but I have noticed a lot of genetic germline mutations like BRCA2, ATM mutations in that populations. They joke here in our practice that I am the BRCA, running a BRCA clinic there because we have seen a lot of BRCA. I mean, I just found out one yesterday. So it's a very poor area. I mean, very underserved, very high incidence of cancer, but also it's underserved with oncologists. There is a group at St. Francis that have been there for 25 years. They have been doing a great job there. There's 3 oncologists. LSU send 1 oncologist every day there, so you have 4 oncologists that covering this area.
Wow.
Compare that area, which you have almost the same population as Shreveport, you have about 29, 31 oncologists here in this area. So it's an underserved area for sure. So that's why I'm gonna start with 2 days to 3 days in Monroe in June, and we'll see how the practice go. If it gets busy, then we need to figure out what we need to do differently there.
Right.
In Shreveport, I will be here a couple of days a week. I'll be joining Dr. Katisha, see how it goes.
Yeah, that's awesome. That's exciting.
It is.
Yeah, I love that. I had no idea that Monroe was that underserved with oncologists.
Yeah, it is. I mean, LSU is really busy. I know St. Francis is a really busy practice. It's really difficult to get people in quick enough. Like even for me now, if a new case of cancer come in, and I'm booked 6 weeks out,
Yeah.
and if a case that I look at, I was like, it need to be seen immediately, then I have to overbook.
Yeah.
So yesterday I have to overbook a new case of triple negative. So it's a lot.
So then there's a triangle. So you got the patient, the doctor, then the overbook situation.
That's exactly.
And then everybody's upset that there's overbooked, but you're just trying to do the best you can. To
Overbooked, and then they come in and it's busy clinic and they wait a long time and they're not happy about it. I mean, I get it, but I mean, at the same time that
there's 4 people here doing the job of 30.
yeah, exactly.
That is very eye-opening. What, as a physical therapist, is there anything I can do? I don't even know, to help with the early detection. Is there any signs other than you just have to do the blood work? I mean,
Well, I mean, as I think of for you, there's a 2 prongs that you can look at it. First, for diagnosis and prevention, I think asking the right questions is important. So, like, if a patient is a smoker and have been smoking for a while and they're above the age of 50, simple questions: does your primary care do your CAT scans for screening? I mean, knowing that question, that simple question, may save their life, because then they can go to the primary care and say, can I do a low dose CT scan because I have been smoking for 20 years? Have you done your colonoscopy? Have you done your mammogram? Have you done, your pap smears or PSA? Those are the cancers that we have prevention and early diagnosis to. So, if you can structure that on your initial history and physical, there's just 5 questions.
Yeah.
For those 5 cancers, very simple. As long as the patient is 40 and above, we can ask those 5 questions as the standard questions for those patients. And honestly, like, if you save one patient out of 1,000,
Yeah, that's great.
of 1,000 times you ask 5,000 questions, and one patient just saves them by diagnosing them on a stage 2 lung cancer, for example. You save their life.
Yeah. No, I love that. Because I'll be honest with you, I've been a PT for 16 years, and in a week it'll be 16 years, and I probably have never asked that. Because, I've asked about mammogram for women, but, CT scan, pap smear, mammogram, all this, that's super easy.
And the PSA, and all of that is really easy to do. All of those are really, really easy to do. It just need to be done.
Mm-hmm.
And it starts with a question.
Yeah.
If we ask as a community, as a medical community, we ask the right questions, you save a lot of suffering. And you save a lot of money.
Right.
Because the cost of treating a stage 4 lung cancer for 2 years is beyond imagination.
I believe it.
So if you do a CAT scan, low dose CAT scan yearly, and you diagnose at stage 1 or stage 2 lung cancer, then you save a lot of money in the back end, but you save a lot of suffering. You have to think about how much suffering you're saving for that patient, their family, their kids. If you can do that, that's how you look at it.
Yeah.
The sufferings that you save by asking a simple question. The other thing you can do as physical therapist is when the patient is diagnosed and now they're going through the chemotherapy or the treatment, the most common side effect that across the board, regardless of what treatment you're doing. So you have targeted treatment, you have chemotherapy, you have immunotherapy, all these category of treatment in cancer treatment. The most common side effect is fatigue. And fatigue is annoying because there's not much you can do. For me, as I'm part of this triangle angle, I am trying to get the patient the best outcome. But if the patient feel that when they wake up in the mornings, they can literally get out of the bed because this is tinea, this is fatigue. There is some tricks that we do with the patient, like keep activity, sleep well, and all of that. But if you can figure out a way to, through physical therapy, to relieve that fatigue, it would be a great point. That's what you can do in the treatment.
Yeah.
And then also they get weak and tired.
Sure.
and all of that.
Sure.
I think physical therapy, my hope is when I join the private practice, I will have a more comprehensive approach to a patient.
Yeah.
It would be a patient-centered care. So we would have, I take part of treating the patient from cancer, but you're also going to have a dietitian, physical therapist, psychotherapist, and if you can get, I hope insurance can pay for all of that, then that's what big centers do.
Yeah, right. Give good care.
Yeah.
That's holistic.
Holistic,
Yeah.
more holistic.
I think sometimes when people say holistic, we think woo-woo or whatever, but no, we want to have all the professionals taken care of.
It's just like, most patients, you give them treatment, even with a targeted treatment, they're not eating well.
Yeah.
They're fatigued, they're weak, they're not sleeping well.
That's right.
You have the stress of the diagnosis, they're facing their mortality. you and I don't know how that feel if you have a stage 4 cancer,
No.
and we don't know how we're gonna feel. I mean, like if we have, God forbid, like we have a stage 4 cancer, whatever cancer it is, you know you're gonna die at some point from this.
Right.
This is gonna be the
This is it.
terminal
Yeah.
event. And now you have the hope, you have the stress, you have the financial stress, you have the stress of looking at how I'm gonna take care of my family, how I'm gonna survive that, who's gonna take care of my kids,
Yeah.
who's gonna take care of me when I'm really sick and I can't take care of myself anymore. All these thoughts, it goes in their brain all the time. And our job is to make that easier,
Yes.
to try to get them through it.
Yeah.
So I think that's what we should try to do with a comprehensive approach.
Absolutely. And again, patient-centered,
Yeah.
client-centered. So so you're going to be in your new practice in Monroe and here in Shreveport. How are people going to, are you taking new patients immediately?
Yeah, I'm taking new patients immediately. We'll announce it probably mid-May or end of May, where we have all the phone numbers and
Gotcha.
addresses and all of that.
Yeah, and I'll list all that on here.
Yeah.
So, okay, perfect. Dr. Ghattas, thank you so much.
Appreciate it. Thank you for coming today.
Yeah,